Yeah, thank you so much, Sydney. Well, thanks everybody for joining today. I hope you all are enjoying your summer. Definitely, there's been wonderful days here in Virginia. So today I'm going to share some of the things that we're working on here at the center. And the goal is really to also get your feedback. This hopefully will generate some good discussions, some insights that you can provide. The data collection is still ongoing. So we haven't, not the data collection, the data analysis is still ongoing. So we're not done yet. But this is some initial, data that I want to share with you, and I would love to get your thoughts. So the focus is really on statewide protocols. As you know, statewide protocols are protocols at the state level that allow pharmacists to prescribe or dispense or administer certain medications. The scope of the protocols varies from state to state. Here in Virginia, we have contraception, naloxone, epinephrine, HIV, PEP and PrEP, vaccines, prenatal vitamins, lower out-of-pocket expenses, and the tuberculin skin test, which was news to me before I started this work. So as I mentioned, the adoption of statewide protocols across the country really varies. The states are at different levels of passing legislation and then adopting and then implementing. We can see that here in Virginia, we have, for example, for test and treat, independent test and treat authority for at least one condition. But specifically, if we want to look with more granularity at the data, APHA, and this is data from 2024, so things move really fast. 2 years later, these may be slightly changed. But as of 2024, there were only 5 states that really had prescriptive authority for all of these conditions: COVID-19, influenza, RSV, and streptococcal pharyngitis. And in Virginia, we were amongst 4 states that had prescriptive authority for test and treat for COVID-19, strep, and influenza. Similarly, if we think about hormonal contraceptives, this data is more recent, July of 2025, obtained through NASPA. We see that here in Virginia, again, we have independent authority to prescribe both oral contraceptives and then emergency contraceptives. The map really displays the variability of legislation across the different states. Just another example, HIV, PEP, and PrEP. Virginia is amongst only 10 states that allow for the initiation of treatment, dispensing, and administration of HIV, PEP, and PrEP. So I think with all of this taken together, we can say that we are in a pretty good spot here in Virginia, and we do have a good regulatory infrastructure to sort of build off of. And we know that since 2020, there's been introduction of more new protocols, and these really come from a collaboration with the Board of Pharmacy and the Board of Medicine. However, we still see that the uptake in clinical practice is slow. Obviously, we have a temporal factor here. We need to allow some time for things to really be implemented, worked out, all of the kinks, and then, roll out the programs. But we wanted to understand a little bit more what is really driving implementation or hindering implementation or adoption of these protocols in clinical practice. So some of you have seen this data already. So we've done prior work on pharmacist uptake of statewide protocols. It was a qualitative analysis we conducted between 2024 and 2025, so very recently. We have interviewed 16 community-based pharmacists here in Virginia, a good mix of rural and urban, chain and independent, younger and older or more experienced. So we did have that. We did pay attention to having like a good heterogeneous sample to really gather as many insights on the situation as possible. We used an implementation science framework to really provide a good approach, a good structure on how to ask questions on what factors to look at, and then in reporting the results. So several facilitators emerged from this analysis to the adoption of statewide protocols in clinical practice. As far as the innovation, it was really, the protocols were really perceived as having relative advantage. So they allow pharmacists to provide, to improve access to care to populations, to provide services that otherwise they wouldn't be able to. So a really good advantage at that point. And then in terms of the outer setting, the existence of very clear protocols that were developed by the Virginia Board of Pharmacy and Virginia Board of Medicine collaboratively really provides clear regulatory frameworks for pharmacists to practice under. There was a big sense of a mission alignment, the pharmacists recognizing that with the use of these protocols, they could almost unleash their full potential in providing services to the populations that they serve and that may otherwise not have access to. So a really strong alignment with their mission. And then at the individual level, it's very similar, knowing that you are being able to provide services and care to patients and vulnerable populations that might otherwise not have access to that care. So a very strong list of facilitators and things that, really, really drive the adoption of these protocols in practice. As far as barriers, complexity of the protocols emerged as one of the barriers. One of the things that we've learned as well is that sometimes the protocols are so prescriptive that they become a little restrictive. And what do I mean with this? They're so very well outlined, the inclusion and exclusion criteria, that sometimes in clinical practice, when you roll out the inclusion and exclusion criteria when assessing a patient, a lot of the patients end up not qualifying for the service and you're left, without the ability to provide services under that protocol. So that's been some feedback that we've heard post-analysis and post-publication that really falls into the complexity aspect here. In terms of the outer setting, limited access to clinical data, sometimes not having full access to the patient information hinders the protocol use. This is paradigmatic for HIV PrEP, for example, where you need access to laboratory data to confirm that the patient is still HIV negative in order to be able to prescribe, the next round of PrEP. Obviously, in terms of staffing and the operations within the pharmacy, and that's what we talk about inner setting, the sort of the workflow integration, the time constraints, the staff available, to fill prescription and to provide the services. So sort of trying to find that sweet spot within the pharmacy operations is also can be challenging. And then in terms of workload limitations from the pharmacists, many of them referred already feeling overworked and being hesitant to add any more responsibilities to what they're already providing. So in a nutshell, these were the facilitators and the barriers. We have published, the full analysis and happy to share if you all are interested and if you don't have access through PubMed. Some other interesting aspects that we found from the qualitative analysis that you will see we're going to triangulate back with the findings that I will present in just a minute was that the chain pharmacists sort of appeared as not being the drivers of implementation of these statewide protocols because they felt overwhelmed. They felt that the leadership would just sort of answer to corporate, and so it would be just a top-down sort of decision-making process. So as far as the role of my supervisor in implementing, they essentially relay the information from corporate to me. So this is a quote from one of the pharmacists that participated. And so, and then, on the contrary, independent pharmacists really share the notion that the leadership was very involved and very supportive in implementing the protocols, and that's very visible in this quote. Our new owner is all for promoting and getting the remaining protocols that we don't have in place implemented. So just from this qualitative analysis, it looked like independents would have more autonomy, which may still be true, more autonomy to implement the statewide protocols than the chain pharmacies. And then another interesting aspect that came up from these interviews was that even though the rural pharmacists, independent pharmacists, often faced more challenges in terms of implementation with geographic isolation or limited patient volume or reduced access to professional support networks to really implement new things. They really emerged as innovators if the protocol addressed a need of their population. And so it'll be interesting, to see what the results are in terms of the quantitative analysis that I will share with you in the next slides. So in market research and in healthcare, we talk about the diffusion of innovations theory, where basically, in order for you to start using a new product, whether it's a technology, whether it's cell phones, whether it's the new, I don't know, the crazy VR glasses that I don't know if anyone bought, but we talk about the diffusion of innovations theory. And here you have, the initial people who are, very non-risk averse, who want to try new things, who are very interested in implementing new things, will be our innovators, and they're the beginning of the curve. So this tail, the 2.5%. And then as they share their experiences and more people and the early adopters sort of start to use that new innovation or technology or product or service. And then, as more experience builds up and you really see in terms of pharmacy, the added value of new services and the revenue potential, et cetera, then you have the early majority here. So more people, as you see, more people adopting the service. And then, those that are a bit more risk averse are going to be the late majority. And the very last ones to adopt an innovation would be the laggards. And so here people want the newest things, and here people want to complete solutions and convenience. So it's once it's established and we say, okay, you guys go first, and then I'll watch and see how good it is for you. Then at that point, then I will adopt. I need enough evidence to see that things are working out for you. And so based on some quantitative data from the Virginia Workforce Survey data and from our qualitative analysis that we've published here, we believe this is where we are. We are still in the innovators stage. For some things like immunizations, we are in the early adopters because more and more people are using the protocols, to provide immunizations. They've done it, since the 90s and really that's what we need for all of the other services. But we're pretty much here in the beginning of the diffusion of the innovation. And so focusing really on this, our question was, who are these people? Like, who is really implementing these services? Who is really utilizing these statewide protocols in practice? What do they look like? What are the characteristics associated with adoption? Is it related to the pharmacist, or is it related to the pharmacy setting and the leadership and the structure of all of that? And so we really want to characterize these early adopters. So specifically, we seek to identify the pharmacist characteristics, as I mentioned, and then really compare the delivery of services under statewide protocols by practice setting. Community, hospital/health system/clinic-based versus everything else, and then independent community-based pharmacies and chain community-based pharmacies. So that brings me to the analysis that I want to share with you, and I want to highlight this is we're still digging through and making more analysis. So any ideas you have, please send them my way. We're more than happy to bounce ideas off of what would be helpful in clinical practice for us to know. But we are using data from the Virginia Pharmacist Workforce Survey. And we are using the 2024 data, which was the most recent when we began this analysis. I know the 2025 is already available, but we've started with the 2024. And the pharmacists that we included in our sample were those who reported being employed and working in Virginia in the year prior, so 2023. And the survey does not include those who have not renewed their license, obviously, those who have not done it online, and some newly licensed pharmacies in 2024 that may have been captured after the survey. So our variable of interest, our dependent variable, is going to be use of at least one protocol, yes or no. And then for each of the protocols approved here in Virginia, we did separate analysis. So for each of them, for contraception, naloxone, epinephrine, test and treat, immunizations, etc. Our independent variables are going to be the pharmacist characteristics and sort of the setting where the care is being provided. So we looked at pharmacist age, pharmacist sex, whether they completed additional training like a PGY 1 and 2, whether they were board certified, and then the pharmacy type in terms of being chain or independent, and then being community or health system or other. Again, at this point, we conducted a simple logistic regression where basically we only have these two variables, our dependent and our independent, and we will look at the association between them. So who did we include in our study? We included, after applying the inclusion and exclusion criteria, 5,690 pharmacists. That's our sample. 70% of which were female. A majority, about 65%, were under 50 years of age, so a young pharmacy population. And then almost a third, so 20.5% were PGY1 trained. And then about 10% had a PGY2. As far as primary workplace, a majority worked in community-based settings, 43.9%. 38.3 were in a hospital or health system. Sorry, there's a word missing there. Health system and clinic-based. So we lumped all of those together. And then 17.2 were in other settings. It just makes the analysis easier. In terms of community pharmacy type, for all of these 43.9% that were community-based, 80% worked in chains, and about 20% worked in independent community pharmacies. So this is what our sample looks like. So of our total respondents, our 5,690 pharmacists, 34% self-reported using at least one protocol. 34%. Of these 34%, these almost 2,000 pharmacists, most of them were using statewide protocols in community, which is not surprising, right? 6.9% in community, 19.4% in hospital, health system, or clinic, and then 12.6% in other settings. There's another analysis which we are conducting in parallel, in tandem, and it's focused on the health system. So for those in the health system, the use of protocols is lower, as we see, 19.4%, but then the use of or the self-report of performing chronic disease management is much higher. And this is captured for hypertension management, diabetes management, anticoagulation, hyperlipidemia. I think that's all. So we're also looking at that, and those are more related to the health system and not so much the community. But here, the focus is statewide protocols, and we see that the big drivers are the community. So what specific protocols are being used in each setting, you may ask? So in community, immunizations, at the top of the list, 54.8%, not surprising. Naloxone, also not surprising, 42.9%. Slightly surprising to me is hormonal contraception at much lower proportion, so 16.2%. If you know anyone delivering contraception out there in the community, in rural areas, please send them my way. I want to talk to them. I want to learn more from this implementation. And then less than 10% for all of the other ones: epinephrine, out-of-pocket expenses, emergency contraception, prenatal vitamins, tobacco cessation, travel medicine, HIV PEP and PrEP, and tuberculin skin testing. So less than 10%. But most of them, about 2-3% usage, especially for HIV PEP and PrEP. So not a big uptake. So hospital, health system, they are providing at much lower proportions, as we can see, but at the top of the list is naloxone, 11.9%, and then immunizations, about 8%, and tobacco cessation, 5.7%, which I can understand that. A lot of the clinics and ambulatory-based could be providing tobacco cessation services. And then less than 5% here for hormonal contraception, epinephrine, out-of-pocket expenses, all of the other protocols. Other settings, immunizations, naloxone, tobacco cessation. So very similar here. Immunization slightly higher than naloxone, but all of them, at very low proportions. So big driver, community pharmacy. Top protocols being used, immunizations and naloxone. All good. Everything is matching up with what we expected. Now we want to understand what are some of the characteristics of the pharmacists that self-reported providing services under statewide protocols are associated with delivering these protocols. So as far as age, pharmacists aged between 50 and 59 were 43% more likely to use the naloxone protocol than those less than 30. I don't know what to make of this. If you have more ideas, please share with me. I'm eager to learn more. And then similarly, pharmacists aged 50 to 59 and over 60 years old, 29% and 60% respectively were less likely to use the tobacco cessation protocol than those less than 30. Again, if you have any insights, I'm more than happy to hear those. I don't know what to make of this data. I don't think it's very informative to us at this point. As far as sex, reported sex, male pharmacists 13% less likely to use at least one protocol, but note that the p-value 0.048 is very similar to our threshold 0.05, and there were no significant differences for any of the other protocols. So I don't think this is like a very relevant to us. But what is relevant and what we I think counterintuitively thought would happen the other way around, but now that we see the data, it makes complete sense. In terms of the highest degree, baccalaureate, so pharmacists who have a baccalaureate were 23% more likely to use at least one protocol. And then specifically immunizations, and then less likely to use tobacco cessation compared to doctorate degree. And let me give you a little bit more of information here about the credentials of the pharmacists. Pharmacists without a PGY1, so no PGY1, were 64% more likely to use at least one protocol. And very specifically, contraception, emergency contraception, naloxone, and immunization. So all of these expected, as we've seen before. And so to me, this tells me that, yes, it's the pharmacist that received its training and went out and works as a pharmacist. It doesn't have to be residency trained. It doesn't have, it does, as you will see here, it does have to have some special, certifications to conduct immunizations, etc. But it's the pharmacist. It doesn't have to be, the PGY1 pharmacist, PGY2 pharmacist trained that are delivering these protocols. They are accessible, to all of the pharmacists. And then, interestingly, which kind of makes sense to me as well, pharmacists without a PGY1 were less likely to use the HIV PEP and PrEP protocols and tobacco cessation. And we will see that these are a bit more common at the health system level than at the community. So very similar findings to the PGY2 training as well. PGY2, again, very, very associated with health system and training at the health system level. So as far as board certification from the Board of Pharmaceutical Specialties, pharmacists without a BPS certification were 33% less likely to use at least one protocol. So, and then here again, less likely to use contraception, prenatal vitamins, naloxone, epinephrine, out-of-pocket expenses, HIV, PEP and PrEP, and tobacco cessation. So just a lot of data. Bear with me. We're almost there. But I think the main messages here is that it's really not the pharmacist characteristics in terms of age and sex. It's a little bit of the training is associated, but not in a way that we thought, oh, more training, more, likelihood of delivering under the statewide protocols. No. And I think that's very encouraging for the profession, is that these protocols can be implemented by people who are not residency trained. In terms of the primary work setting, as I mentioned, so working in a health system compared to working in a community-based pharmacy is pharmacists are 85% less likely to use at least one statewide protocol. So more of the chronic disease management services are being implemented in the health system or clinic-based or hospital, and more of the statewide protocols in a community-based pharmacy. And then, specifically for some of the protocols, health system less likely to use contraception, emergency contraception, prenatal vitamins, naloxone, epinephrine, out-of-pocket expenses, and immunizations. So that's all expected. In the health system, more likely to use tuberculin, HIV, PEP, and PrEP. HIV, PEP, post-exposure prophylaxis, this is important, tobacco cessation, and then travel medicine. So I think we can see, we could anticipate some of these findings. And then we also had a variable that we categorize as those practicing in counties that are metro and those non-metro counties. So pharmacies working in non-metro areas were 50% more likely to use at least one statewide protocol. And if you recall the results from the qualitative analysis that we did before, they did appear as some of the innovators in this area. And so it's sort of triangulating this information is really providing more, I think, strength to the thesis that, yes, rural pharmacies do play a very important role. So again, specifically for each protocol, non-metro areas more likely to use contraception and immunizations than metro areas. And then less likely to use emergency contraception. All right, this is a little bit of a busy table here, but I'll walk you through it. I just didn't want to put more and more words as we did in previous slides. But very simply put, this is the comparison of chains and independent community pharmacies. So what we see here is for the use of at least one protocol, chain community pharmacies are 81% more likely than the independent community pharmacies to be using at least one statewide protocol. And you will see this, that chains are more likely to provide for the contraception protocol, 2.6 times more likely, for the naloxone protocol, 2.3 times more likely, and for the immunization protocol, 90% more likely. And we've seen this before, the top protocols, contraception, naloxone, immunization in community-based are being dispensed, are being used in the chain pharmacies more so than in the independent pharmacies. The chains are driving the implementation. As far as the independents, these were more likely. I know the comparison here is chain versus independent, so I'll just say that the chains are less likely to be delivering or to be using the out-of-pocket expenses protocol, the tuberculin protocol, and the tobacco cessation protocol. So the independents are doing more of this. Okay. So what are the main takeaways? And we'll have plenty of time for discussion and to share, bounce ideas off each other. Main takeaways: pharmacists with a baccalaureate and no residency training are more likely to use at least one statewide protocol. Pharmacists without BPS certification are less likely to use at least one protocol. Community-based pharmacists are more likely to use statewide protocols compared to health system pharmacists. So big drivers there. Pharmacists working in non-metro areas also more likely to use at least one statewide protocol. Chains are driving, more likely to report the use of at least one statewide protocol, specifically immunizations, naloxone, and hormonal contraception. And then the independents are more likely to use the out-of-pocket expenses, tuberculin skin test, and tobacco cessation. In terms of, as I mentioned, this is an ongoing research. We're thinking of doing multivariable, so adding more confounders to the model, making more sophisticated models, looking at some interactions that may exist in the data. But really, I think this gives us an opportunity to reflect on what's happening. The chains are really driving, and we know that here in Virginia, there's a specific chain that is really pushing for the implementation of these protocols, as well as credentialing all of their pharmacies, all of their pharmacists to build Medicaid, and sort of, drive the innovation and drive the implementation of the protocols and, consequent Medicaid billing. And I think more chains will follow suit. And eventually they will make the case for the independents to follow suit and really understand the value of providing these services. But the value, and I think some of the things that we got from the qualitative analysis in seeing that the chains can be more rigid in implementing things or in innovating, the chains are driving that change. And I think that the top-down approach is really promoting more of the widespread use of these statewide protocols. So more so than the specific characteristics of the pharmacist, it looks to me that it's the setting that's determining really who adopts and who does not adopt the statewide protocols. Obviously, supporting the independent pharmacy owners who are faced with many more challenges in terms of viability and sustainability and the financial operations of a pharmacy is vital. Working with them, and we have plans to do that, to create business models, to sort of start to demonstrate the value of these services are things that will be incredibly helpful and sort of help to make the case to expand to other independent community pharmacies. Couldn't finish this presentation without acknowledging the Virginia Department of Health Professions, who is always incredible partners to work with, provide the data in a timely fashion. Dr. Yeti Shobo, Barbara Hodgson, very helpful in providing access to this data. Our student, PharmD student, who's been doing this initial analysis, Joelle Nulu, and our student, a PharmD student from Auburn University who participated in the AACP SAS Exchange program, Jonathan Mann, all of the CPPI core faculty members, and some future collaborators that we will have in this work. So it would not have been possible without them.